Good evening, everyone. We welcome you to the second webinar of Maha Smiles, Cleft Care for Every Child by Smile Train. I would like to introduce Ms. Renu Mehta, the Area Director, South Asia for Smile Train. Over to you, Renu ma'am.
Thank you, Shrutika, and good evening, everyone. It gives me a great pleasure to welcome you all to the second session of Maha Smile, Cleft Care for Every Child, the webinar series that we are doing it in partnership with the Association of Maharashtra Ops and Gynae Societies, Science Integra, and our valued CSR partner, Bajaj Finserv. Shrutika, if somebody can change the slides. I would like to let everyone know a little about this program that we have in collaboration with Bajaj Finserv. So as the name is very, very clear, this is a CSR collaboration. And through this collaboration, we aim to build awareness and support treatment for children with cleft in Maharashtra. Through this program, we are envisaging that we will enable nearly 8,000 cleft surgeries who are residing in Maharashtra in the period of 36 months, that's coming 3 years. The awareness that will be created through these webinar series will be about the importance of timely treatment and timelines of cleft treatment. So through this webinar, AMOX and Science Integra, we aim to facilitate resources amongst the AMOX community about diagnosis and also build linkages between the members of the society and Smile Train treatment centers so that children who need these surgeries, the parents, if they have any queries, they can get in touch with these partner hospitals and get timely help. In Maharashtra, we have 11 treatment centers across 10 cities, and these are all highlighted in the map that you can all see. And if you find any cleft children, please refer them to the nearest Smile Train partner hospital in Maharashtra. They can also call our toll-free cleft helpline, which is 1-800-103-8301. I would like to now welcome Dr. Sujit. Dr. Sujit is a chairperson of Fetal Medicine Committee of AMOX. He completed his basic ultrasonography training at Dr. Bimal Sahani's Sono Scan Center, Aurangabad. He is Fetal Medicine Foundation certified for 11 to 13 week scan, PE screening, Doppler ultrasound, and fetal abnormalities. He is also the Secretary of Society of Fetal Medicine Marathwada chapter. And he is also the moderator of this webinar today. And now I hand over to you, Dr. Sujit.
Good evening, respected dignitaries and delegates. Thanks a lot, Renu ma'am, for this nice introduction. Today is the second episode of the AMOX Smile Train webinar. First episode was very nicely attended by so many delegates. I assure you, Mehta ma'am, that this webinar will help in a tremendous way to encourage all clinicians and related people to improve the way in which you are working. So it is great honor to welcome our President AMOX, Dr. Rajan Singh Pardesi, and Secretary Dr. Sujata ma'am for this. As we all know, Smile Train Foundation is an NGO which is working for treatment of cleft lip and cleft palate, which is very correctable congenital anomalies. We are going to learn many more things today about that. Dr. Pardesi sir and Dr. Sujata ma'am, as President and AMOX, President and Secretary, as a lot thanks to them because they have provided a good platform to discuss all these things along with Smile Train. I think they have not joined. So straightway, we'd like to move to our scientific program. I would like to welcome and request Dr. Rashmi Khan ma'am for her talk. She is going to talk on overview of cleft lip and cleft palate. Dr. Rashmi is chairperson AMOX High Risk Committee, High Risk Pregnancy Committee, Organizing Secretary AMOX 2020. She is secretary. She has been secretary Amravati Ubujaya Society 2019-20, joint secretary ISOPOP Vidarbha chapter, West Zone Coordinator Foxy Breast Disease Committee, Three
Thank you very much, sir.
given.
Thank you, Sujit, sir.
There is a long list. I may feel breathless. So, so I request me to start her talk.
Thank you.
Please share your screen.
So thank you very much, Sujit, sir, for this very kind introduction. My regards and respects to Dr. Pardeshi, sir, and Dr. Sujata Darbi, madam, the president and secretary of our MOX, and also the all executive office bearers of MOX. And many thanks to Science Integra, Smile Train, Bajaj Finserv, respected Renu Mehta, madam. And we are looking forward to talk by Dr. Karun Agrawal, sir, and many thanks to Shrutika, the very wonderful coordinator of this Smile Train. And I'm Dr. Rashmika, and I'll be talking on cleft lip and palate and open lip. So as we all know, the cleft lip or the palate is the most common anomaly of orofacial region. These birth defects occur when there are splits in the upper lip and mouth, which occur while a fetus is developing in uterus. It can occur isolated, or sometimes it can be observed in combination in various conditions, other congenital conditions, especially the congenital heart diseases. And it is very important that patients with orofacial cleft deformity should be treated at the right time and right age, so that we can provide a very good function and aesthetic well-being to the baby. It is also important that the cleft lip and palate is going to require a multidisciplinary, interdisciplinary, and a very coordinated approach. And the specialists that will be involved in the care of this condition includes an OBGYN, as who will be taking and detecting in the antenatal period, maxillofacial surgeons, plastic surgeons, geneticists, speech therapists, psychiatrists for psychiatric support, and also the neonatologist. Cleft lip is formed, as we all know, due to the failure of fusion of frontonasal and maxillary processes. This results into a cleft of varying degrees, which extends to the lip, alveolus, and nasal floor. Cleft palate occurs when there is failure of fusion of palatal shelves of the maxillary prominences, resulting in cleft of a hard and soft palate. Cleft arises during the fourth development stage of embryonic life. They appear exactly when at one particular location, facial prominence failed to fuse. This is also influenced by some interference in development in embryonic life. So as we all know, as we have already learned in embryology book, that the frontonasal prominence, it develops into the medial and lateral nasal prominences. And two maxillary prominences, they grow towards the nasal prominence and create nasolabial region and lip. This fusion, if failed around 5 weeks, leads to formation of cleft lip. So the morphology of the face is basically 5 fundamental facial prominences. And the primordial mouth is formed at 4 weeks of gestation. These 5 fundamental facial prominences are 2 bilateral maxillary prominences and 2 lateral mandibular prominences. The frontonasal prominence develops into the medial and the lateral nasal prominences. The 2 maxillary prominences grow toward the nasal prominence and create nasolabial region and lip. The fusion is failed around 5 weeks, leads to the formation of cleft lip, and at the same time starts the development of palate. It is completed around week 12. The medial nasal prominence fuse in the midline to form the primary palate, and the medial side of maxillary process rotate and develop into lateral palatal processes and fuse in the midline to form secondary palate. The failure of midline fusion leads to cleft palate. So what this reference carry importance? This reference and embryological aspect of development is very, very important in the diagnosis of cleft lip and palate antenatally, because as we all agree, the routine antenatal care of a patient involves an early anomaly scan at around 11 weeks and the next anomaly or the structural scan at around 18 to 20 weeks. And these two scans can detect and give us idea about the presence of cleft lip and palate. And what is the importance? The imaging of upper lip is very important because in prevalence, it exactly equals to the prevalence of a Down syndrome. The diagnosis of cleft lip and palate antenatally is also important because it can be associated with other congenital malformation, and it will lead us or give us a clue about the existence of other congenital anomalies in the fetus. As we have extensively learned in last webinar about the sonographic features and diagnosis of cleft lip and palate, we won't be going into the details of it. But as we all understand, that prenatal detection of cleft palate is a challenge in prenatal diagnosis. The challenge in detecting or visualizing cleft palate is evident from low detection rates. Even if cleft palate is suspected, the diagnosis accuracy sometimes it remains low. At the present time, high-resolution 2D echo and experts in the fields like Dr. Sujit Ponkar, who had given us extensive lecture last time, this webinar we covered, last time we covered it all in webinar, is a mainstay in the diagnosis of cleft lip and palate. So now we have this equal sign. The normal uvula could be visualized with typical echo pattern, that is equal sign, and gives us an idea that the palate is intact. The absence of the equal sign gives us a clue that yes, we have to go deep and search for the presence or absence of cleft palate. The incidence of isolated cleft lip is 50%, isolated palate is 40%, and the incidence of cleft lipped palate in combination is 45%. The cleft lip palate can be syndromic type. It is due to the single gene disorder. We also call it as Mendelian disorder. It is generally associated with other malformations. It occurs in more than 400 known syndromes and follows a classical Mendelian inheritance pattern. Some examples of the other syndromes are DiGeorge syndrome, fetal alcohol syndrome, Zollinger syndrome, etc. The other type of cleft lip palate is a non-syndromic type, which occurs in 70% and is multigenetic. There are some non-genetic factors which influence and which are the causative agents in the formation of cleft lip or palate in uterus of mother. And these are the smoking history excessive smoking history in mother, alcohol misuse, some kind of stress, maybe biochemical or psychosomatic, exposure to some chemicals, advanced age of mother, diabetes in mother, and exposure to some drugs like valproic acid, phenytoin, which we use in the treatment of epilepsy, or there can be a retinoic acid exposure. So as we all understand that when a baby is born with cleft lip and palate, the baby is definitely going to have feeding problems in neonatal life. And that is going to lead to failure of thigh. The baby will have speech problems. The baby will have auditory problems, maybe secretory type of otitis media. The baby will have multiple dental problems also. So what is the management of cleft lip and palate holds? The management of cleft lip and palate holds a thorough education. Because as we all know, this is a world of aesthetics. So handing over a baby undetected with a cleft lip or a palate to the mother or to the relatives is going to put them in a sort of shock condition, because this is a deformity which is obvious from the outside. So if we detect this anomaly antenatally and counsel the mother and the relatives about the presence of this anomaly, and we take help from other specialties like the involvement of plastic surgeon and neonatologist, so we have commonly observed that the rate of continuation of pregnancy in these mothers is very high. So proper counseling of the mother and also the relatives is very important. We have to direct them to the treatment at the right age and right time. And we have to assure them that these anomalies are correctable and the baby can lead a near normal life in future. Because of the aesthetic value and some social conditions, the patient and the relatives will also need some psychosocial rehabilitation when cleft lip and palate is considered. So this is the mainstay of the treatment of the cleft lip and palate. It is a condition which needs a multidisciplinary, interdisciplinary, and a very coordinated approach. It will need antenatal diagnosis by the fetal medicine expert, an obstetrician's view in counseling her and making her understand that this is a correctable anomaly and can be corrected. The baby can live a normal life. Peer support group and psychosocial rehabilitation, involvement of plastic surgeon, and yes, we'll be learning more about this in next talk. Thank you very much.
Thank you, Dr. Rashmi. This has been very nice overview of cleft lip and cleft palate. We have covered so many things. So this will lay some you can say introductory part of this today's webinar. Now I request respected Dr. Karun Agrawal sir for next talk. Respected sir is a very senior consultant plastic surgery, National Health Institute, New Delhi. He is member of Global Medical Advisory Board and Indian Medical Advisory Council of Smile Train. Retired as Head of Department of Burns and Plastic Surgery at VNMC and Safdarjung Hospital, New Delhi. He has been past President, Association of Plastic Surgeons of India, 2016. Past President of National Academy of Burns India, 2010. Past President of Indian Cleft Society, 2009. He has been recipient of National Teacher Award in 2015. Chief Editor of Textbook of Plastic Reconstructive and Aesthetic Surgery published by Theme. He has been Fellow of National Academy of Medical Sciences, Chairman Ethical Committee, Institute of Pathology, ICMR. So many publications are there. More than 150 journal publications and 15 textbook chapters are associated with him. Agrawal sir, I request you to take over and start your talk, sir.
Thank you, Dr. Sujit. And thank you, Ms. Renu and Dr. Rashmi for inviting me to speak to a very august gathering. Can I share, Dr. Sujit?
Yes, sir. Please share, sir.
Okay. So, good evening, everybody. This topic of cleft lip and palate is very close to my heart and the people who are attending here and organizing here. For all of us, this topic of cleft lip and palate is very close. And I'm not talking about the treatment or the technical intricacies of cleft lip and palate, but I thought I'll just introduce the topic of cleft lip and palate for better understanding for the future webinars. And fortunately, Dr. Rashmi has laid down very good foundation describing the essentiality of multidisciplinary requirement and the difficulties the children and the parents face when the child is born with cleft lip and palate. I must thank the Smile Train as well as the Maharashtra Association of Obstetrics and Gynecology along with the FOXY for starting this webinar series. We had a similar webinar series for Indian FOXY, but this is a very focused area, and I'm sure this will drive the message much closer to all the people who are managing these patients and children. I have no disclaimer about this presentation. These are all the photographs are my own patients, and I have got due permission to reproduce them for presentation here. First question, which when I was talking about this presentation, few of my Foxy member friends, they said, why you need to have such webinar? Why you need to have this presentation for Foxy? They are all well learned and well aware of the topic. You don't need to talk about this. But I thought I'll just design a line diagram which depicts why it is essential. If you see this antenatal period or prenatal period, the first person who comes in contact while detecting the cleft lip and palate is the imaging specialist. This happens as level 1, level 2, whatever level you say. I am totally novice to this, but level 2 is supposed to be a hallmark of the diagnosis of congenital anomalies at 22 weeks or little earlier. So this is the people like Dr. Sujit are the people who really diagnose it first. And now in our OPD, almost like 20% of children are detected prenatally. This is amazing because 20 years back, the percentage was 0. I never got a patient of prenatal diagnosis in previous century. I have been working in this field for 43 years, and at the turn of century only this detection started to this level. After the detection, the imaging specialist talks to the obstetrician, and the obstetrician and the imaging specialist together, they manage the situation of the children or parents to have the baby with cleft lip and palate in their family to come at the time of birth. At the time of delivery, when obstetrician sees the child, this is managed by obstetrician in neonatologist in labor room and thereafter in the neonatology unit. And this is the time when the child is seen as the child with anatomical defect to the family and the parents. And it becomes the responsibility of these two people to take care. And after birth, most of the time it happens that this is too early to send the child for surgery. And the pediatrician manages the child in the initial period. And then, much later in life, I will consider even after 3 months or 4 months, if your patient is referred to the cleft team, it is much later in life. When pediatrician refers the child or obstetrician refers the child to the cleft care team. And usually this happens in my experience around 2 months or 3 months of the age. Even now, the child is referred to cleft care team. So initially, if you see, the responsibility is of the imaging specialist, obstetrician, neonatologist, and later comes the pediatrician and the cleft surgeon and cleft team. So antenatal, after birth, and to adulthood. And what we expect is, during this period, the hallmark of the management is the counseling. And after birth, again, it's the counseling and reference to the cleft team. So if you see initial part of management during prenatal as well as the postnatal early part is counseling and reference. And when it is referred to a cleft team, you'll be surprised to see the list of people who are involved in the cleft team, and they need to take care, which Dr. Rashmi has elaborated in her presentation. You see the formation of the cleft team. It's not one individual. It is not one surgeon. It's the plethora of the specialists. Cleft surgeon, which can be plastic surgeon, which can be maxillofacial surgeon, speech therapist, nutritionist. Now it's Smile Train is giving a lot of emphasis on nutrition and why I'll come little later. Dental specialists of different kinds, orthodontist, pediatric dentist, counselor, otolaryngologist, pediatrician, coordinator. And now we are adding more and more psychologists and clinical psychologists and pediatric psychologists. So many people are involved in managing these patients. And then when the cleft team is involved, it is already a period of 6 months gone. So the whole responsibility of managing and counseling is important for all of us, all the Foxy members, always the cleft care team, to know what counseling should be done. And unless we know about the basics of cleft lip and palate, it will be difficult for us to counsel the parents and the family. That's why this presentation, and it is very relevant to have interdisciplinary discussion between the FOXY members as well as Cleft Clear team to impart the proper counseling and proper education to the parents very timely and very apt. That's why this whole webinar series being planned by Renu Mehta and team. And I feel this will go a long way in managing these children as best as possible. Now, what is cleft lip and palate? I'm not talking too much technical, but I thought it is essential to say that cleft lip involves only the involvement of the lip. The inside of the structure remains normal, but it can occur on one side, it can occur on two sides, or sometimes it can occur in the midline at odd places. But this is commonest, and this is not so common, but this is rare. This is known as cleft lip or group 1. I'm fond of Indian system or Indian classification, so I will just talk about Indian classification, which is Nagpur's classification, part of Maharashtra. And you'll be very happy to know that in spite of starting this classification laid down in 1975 by Dr. Balakrishnan from Nagpur Medical College, we are still following the same classification. This is group 1, that is cleft lip. This is cleft palate is group 2. It can be complete palate from the alveolar arch to uvula, or partial, or it can be subsurface where only the mucosa is united, muscle is not. So this is subsurface cleft palate. We call it as group 2. So group 1 is cleft lip and group 2 is cleft palate. And now it becomes group 3 when palate, alveolus and lip all are involved. So it can be on one side, it can be on both sides. So it will be group 3. When all these structures are involved, it becomes group 3 in Nagpur's classification. It's a little elaborate, but this basic classification is essential to understand and classify almost 99% of children of clefts. Now, some of the questions which we need to know when we are dealing with this plethora of the group of children. This is one of the commonest anomalies of the face. I can't say that it's commonest anomaly because other anomalies are there like hand anomalies or hypospadia. These are commoner than this, but in face, cleft lip and palate is the commonest. In India, almost like 40,000 children are born. You can imagine the magnitude of the problem. And each child requires at least 1.5 times surgery. Some of them require 1 surgery, some of them require 2. So on an average, we require 1.5 surgeries for these children when they are born in India. Globally, we have got 2.5 lakh children born. And if you calculate the 140 crore people in our country, we have almost like 2 million people affected with cleft. They are operated, unoperated, or they are settled in their whole life. But we have got 2 million people affected with cleft. If you calculate with the incidence, it comes like that. And global average is 1 into 700 live births. This is average. Even in India, because we have got different racial population from north to south, our average changes from place to place. And in some places, it is 1 into 500 live births. In some places, 1 into 1,000 live births. Now, this is the question which is asked by everybody when they come to our clinic. Why this happens to my child, or why this happens in my family? As Dr. Rashmi said, it is genetic, but it is known only in 17-18% of patients that we can trace the gene. We can trace the genetic involvement. But in rest, it is all environmental factor, which we have already seen in previous presentation. Now, what is very intriguing for our population is the myths which have been related or associated with this. And these myths, we need to take care when such things are discussed. A lot of things are said that watching eclipse during pregnancy, adultery during pregnancy, using knife and cutting the cucumber and vegetables by the pregnant woman. And in Africa, I was surprised to know that they said that if the mother drinks dirty blood during pregnancy, it will cause. So many things are there which can which are myths in the field of cleft lip and palate. So we have to mitigate these myths in the minds of the parents at the appropriate. Now, what to do after antenatal detection? I come to the counseling part, that we have to take care of this counseling, and this we have to prepare ourselves to counsel the parents properly, and we have to counsel in such a way that they are ready to welcome the cleft babies. I am totally, I can't say 100% that we should not motivate them for MTP, but if it is a non-syndromic, without any association of serious anomalies, one should motivate them not to proceed with MTP, because these are manageable conditions, and we can rehabilitate all these children to a normal individual. Now, while counseling, these are the questions which we come across in our practice. Why my child is affected? What is future of my child? Many cleft children, parents with cleft palate will say, will my child speak? Because some of the dadis or nannies or social people, they will, in society, people will say this child will not speak because he has got cleft palate. How often I do need to come to hospital? When surgical correction is possible? Who is the best surgeon? Who is the best hospital? What are the problems with the child? So on and so forth. So many questions are there. So all these questions we should be ready to answer, and we should be ready, even if it is irrelevant, we should be ready to answer, because these are the people who need to be told. Now, the last question of what are the problems with the child when they born after birth. So if you see these children, they will have airway management, especially the cleft palate if pyrorobin is there. They are concerned about the defects. But what is our main issue is the feeding at the beginning, feeding and nutrition, and then psychological support. And routine newborn care need to continue along with the care of the cleft. This is an example of the child, how nutrition can be affected and how it is. This is not unusual. We see very commonly such situation when the child at 3 months, it is like this. They need to be given nutrition. They need to be given nutrition counseling. And this has happened in our clinic over a period of, you can see, September to February, 5 months, the child has been transformed to this. With due dietetic support and dietetic counseling, this has happened with the help of Smile Train dietetic support. The feeding, the position is important, which the dietitian tells very frequently and counsels the parents. But what is more, apart from the feeding position, is what to give, when to give, how to give, when to change, how long to give, and much more. So these are important for the nutritionist and pediatrician to know about nutrition in cleft babies. Now, cleft lip and palate, I'm sorry if please tell me if I'm crossing the time, we can stop and we can discuss. So, Dr. Sujit, please feel free to stop.
No problem.
Okay. See, cleft lip and palate is basically an anatomical deformity. If you see on the face of the child, it has got defect of the lip, it has got defect in the annulus, defect in the palate. These are visible defects. But simultaneously, it also causes secondary issues of function and psychosocial element. And if I be more specific, the cleft lip is essentially an aesthetic problem, anatomical defect which is correctable. Cleft palate is aesthetic as well as functional problem it creates, and collectively both of them cause the psychosocial problems. Now we can see how surgically we can correct them. As I said, it is anatomical deformity which is correctable. We can transform the child. This is a microform cleft. It is very little cleft of the lip, and it can be correctable with surgery. One surgery is good enough to take care of the child. Little more cleft. This is complete cleft of the lip, single surgery. Again, it is correctable one stage. Little more, if you go to the lip and the annulus, again, it is correctable in one surgery, only the alveolar cleft, which requires little dental care in future. But when the child has got cleft lip and palate like this, where alveolus is involved, it requires two surgeries. One is for the repair of the lip, and second is for the repair of the palate. And you see the child, after two surgeries, becomes absolutely normal to see anatomically on face. This is not the rare child. I have not selected the child which is beautifully seen and good result. We get in almost all the patients the same result when we operate upon this lip and palate. These are the techniques which we do in the lip, and preferred age for lip repair is 3 to 6 months. But after 3 months, anytime it can be repaired. If you have got bilateral cleft, as I said, again, it is repaired in one stage. And you can see the child becomes absolutely normal looking. If it has got bilateral cleft lip, another child where it is more defect is there, again, one stage. And if it has got bilateral cleft lip and palate, 2-stage surgery again, we have to repair the lip one go and the palate another. And you see, it looks so beautiful. Then how we can counsel them against continuing the pregnancy? It is just not acceptable. These are children who are so beautiful looking, so good to see pre-operatively as well as post-operatively. And we operate the cleft lip at the age of 3 to 6 months. And palate, one surgery and the palate becomes normal. You see, even grown-up children, when they come, it requires one surgery and the palate becomes normal. There are many techniques of palate repair, and palate repair is done after 9 months and preferably before 18 months of age. Sometimes we see such children as well. We get plethora of clefts, but this is only 1 to 1.5% of children who are born with caseous cleft or rare clefts. But they also can be managed and can be made normal with surgery. Now, apart from the anatomical defect, as I said, functional and psychosocial elements are to be taken care. And for that, we require comprehensive care. That's the reason why we say cleft se confidence tak. And Smile Train had organized a beautiful conference on this. Cleft se confidence there in your state of Pune, Maharashtra, in Pune. We all from whole walk of Cleft team, we had gone there and discussed about this. And we had attended a beautiful conference. Amongst comprehensive care is speech therapy. It is required for only children born with cleft palate. If it is cleft palate or cleft lip and palate, then only this speech therapy is required. And they are integral part of our team. And for some cases, we need to do surgery to correct the speech, and this is known as the velopharyngeal dysfunction correction. So surgery is also part of speech correction. Then second person who is important is the orthodontics. And they align the maxillary arches. They take care of the cleft gap. They take care of the nose at the beginning. And they also help in feeding when they give some plate for this, and significantly improves the cleft care. You can see this is the child with this cleft, and with orthodontic, this becomes like this. And when we repair these children with cleft, the result is much better. Surgically, it becomes easier for the surgeon to operate. So this is the importance of orthodontics. It is very important in bilateral with protruding premaxilla, where we can give this result only with simple surgery, only because of orthodontic support. And we can see the smile they can create in patients or the people with cleft so beautifully in whole group of people. This is the orthodontics role. Another person essentially important is the pediatrician, part of FOXY, and I'm sure they are all aware that counseling, nutrition, we require their help in before surgery and after surgery to make them fit for surgery and manage them post-operatively. And you can see these are all talking about the primary issues. There are much more than this, but what comes is the final aesthetic surgery and aesthetic correction. You see, any deformity in the nose, some of the patients will be having leftover deformity, especially unilateral cleft is more prominent. We can correct to this extent, and we can correct to this extent, and they look absolutely normal after this surgery. You see this girl, 18 years old girl from Orissa, and this has been changed to this. And now she is the model in her own city, in her own good self. And she has won many prizes in colleges and in social activities. This is bilateral cleft. And you can see this is created. And this gives a lot of advantage to their lifestyle. They become so confident in their life. And sometimes we need to do bone surgery also at later age, after 16, 17 years of age, to make them normal. So what I mean to say is, we have know-how that we can make all of them normal. You see, they all get psychosocial problems. Teasing is there, discrimination there. They get depressed, they get lonely, they get introvert because of the scar over their face, because of the speech, because of the teeth problem. But all of them are correctable, all of them can be treated. And Smile Train is so active. And I don't say only Smile Train, but there are many organizations, even the government organizations are there who are participating in organizing many activities to help these children. And this is, I'm sure everybody will recognize this lady who came to our hospital for awareness program as well as for rehabilitation of these children. We also organize cleft education camps where they mingle with each other and they support each other and they counsel each other. So this is a very important event which many of us organize, and this helps a lot to these parents and children. In 40 years of my career, I have seen total revolution in the management of cleft lip and palate in India. We used to have years of backlog. I remember children, they used to wait for 2 years, 3 years for surgery. And now there is no waiting at all. The child comes today and within a week or 2 weeks, the child is fit and we operate. Now we can have comprehensive cleft care, complete rehabilitation of the child is possible. And it is available to every individual. If you see the care of children with cleft lip and palate, it is amazing. And it is available across the country. We have got more than 140 partners who are managing these patients under the Smile Train. Equal numbers are there in other NGOs as well. And we are equipped to rehabilitate these children to normalcy. So present status, we have highly acclaimed cleft surgeons all across country, plastic surgery surgeons as well as maxillofacial surgeons. And most of these surgeons are high volume so that they are well experienced. And we have got great skill. We get patients from outside to manage these children for surgery. We have got 140 or approximately partners across the country to manage these. And many of them are comprehensive care centers. And many other charities are also contributing. And I don't want to belittle the other institutions, medical colleges and hospitals who are also contributing. I say approximately 50% of them children are being managed by non-Smile Train centers in our country. But we have to use the social media and the technology. And I'm not a technical person, but I'm forced to participate in social media activity for the awareness program. We have got this YouTube, and I am surprised that 50% of now my patients, new patients arrival is through this YouTube. And rest of them, they are referred by Smile Train directly or else, but they have watched these awareness YouTube. So this is essential, and we should all carry on with these type of activities to improve the awareness and the care. And finally, what we want is this confidence. This is Smile. And this confidence, you can see how it exudes in this girl. She is bilateral cleft lip, born like this. And she is now 22 years and she is leader of many organizations. And she is one of the spokesperson of, you can say, consultancy company. As well as she is a poet, she is a very vocal person. And now, such stories give power to these children. This is a boy of cleft lip and palate. And in college, one of the photographers from UK came to choose a person to be a photo model. And you see how he has bloomed. So this is the power of the story and power of awareness and power of the cleft care in India at the moment. So there is a potential to create smile on every child's face, including cleft lip and palate children. The need of hour is to join like Foxy and Smile Train and other organization and every member's association of the Foxy. And we should join hands only to rehabilitate these children as normal individuals and create a meaningful smile in everybody's face. Thank you so much.
Thank you, sir. That has been a very great lecture, great talk. You have covered all those things from basics to classification and all the teamwork, pediatrologists, pediatricians, and orthodontists, all that has been covered. So this has been a moral booster for those who are having some patients or some known person with cleft lip and cleft palate, because the photos which I have shown before surgery and after surgery, they are unbelievable. Usually, even I can say we have not seen such patients post-operatively, because we don't see patients like this. We see we only do imaging part of that part, actually. So this has been very great work by you, sir. There are some questions, sir. First question is, what surgical and non-surgical treatment options are available for correcting cleft lip and palate, and at what age are these typically performed? Actually, this has been covered in your talk, but still, you can repeat your answer, sir.
See, cleft lip and palate, these are two different elements. As I said, cleft lip is operated as early as possible because it is a cosmetic problem. So we need to operate these children as soon as possible, as soon as the children are fit for GA, because this is to be operated under general anesthesia. So we consider that 3 months of age is safer to take the child for anesthesia. And hence, the cleft lip can be operated as early as 3 months and should be operated by 6 months so that the child doesn't remember its defect. After 6 months, the child starts remembering their defect. That's why it should be operated before 6 months. So 3 to 6 months is the time for cleft lip. But cleft palate, we want to delay, because if we operate early, it may cause hypoplasia of the maxilla because of the surgical trauma. That's why the palate repair is delayed by 9 months or still later. So 9 to 18 months, we operate the palate. But it is not a hard and fast rule that we should operate at 9 months or we should operate at 6 months. It has got a range. We can wait. Suppose the child is unfit. The parents need not worry that the surgery is getting delayed. We can wait for a few months. We can wait for a few days. And once the child is fit, then only we should operate. Now, apart from this, sometimes we need to operate these children much later if the child is having pyrorobin anomaly. If the child is not fit for GA and risk of respiratory problem is there post-operative, we can wait still for 18 months or 2 years, and then we can operate. So that is the time schedule for surgery for cleft lip and palate. And types of cleft, as I said, it has got cleft lip, cleft palate, and cleft lip and palate. This is Nagpur's Maharashtra classification. And we cannot forget this classification because my mentor and my chief from PGI, he was there in Nagpur Medical College as chief of plastic surgery. He had established this classification, and it is known as Nagpur's classification or Dr. C.B. Balakrishnan's classification. So it's very easy to remember, and it is very useful, and that has stood the test of time. So cleft lip, cleft palate, cleft lip and palate.
Thank you, sir. About this classification, in my last talk, I came across more than 15 to 20 classifications regarding cleft lip and cleft palate, and I came to know that Karnahan's classification has been very popular. But now today I came to know that Nagpur's classification by Subramaniam sir is the perfect thing. Is it right, sir?
Yeah, actually Karnahan's classification is popular because it has got documentation system. The Y classification, you can document and specify which area is cleft in Karnahan's classification. While it is good for documentation and create a document that this part is repaired, this part is cleft. While Nagpur classification, you can speak on, we can abbreviate, you can computerize. you can archive and you can retrieve based on these abbreviation of the classification. Because group 1, group 2, group 3, it is not possible in Carnahan's classification, but it is possible here. And you can, while discussing, just like I'm talking to you or presenting a case in the ward round, I can say this is group 1 classification, classified cleft, or group 3. But Carnahan's classification cannot be spoken in your ward round. That is only for documentation. But there are, as you said, 18 to 20, I think I can enumerate much more than that, because Ritchie and Williams had started in 2019 the classification of cleft lip and palate. And since then, every 5 years, new classification comes up. So there are plenty of them. But I think for Indian plethora of people who are managing cleft Nagpur classification, I feel proud that we are using Indian classification. I feel proud that one of our known person has established the classification, and it is wholesome. I have modified this classification, added some abbreviations in this classification. It is published in PubMed Index Journal. So it's very close to my heart.
Thank you, sir. The next question is, how do different cultural perceptions and stigmas surrounding cleft lip and palate affect individuals and their families? Again, this is a repetition, but still people want to know.
But very, very, very important and essential to know about this. I have fortunately worked in South for plenty of years. For almost 23 years, I was there in Pondicherry. I am trained at Chandigarh, which is western part of the country. Now I am working in Delhi, which is northern part, and I am brought up in Raipur, which is central part of India, very close to all of you. So I have seen the perception and cultural ethos of all the areas, most of the areas in our country. I can tell you from in brief that cultural, social beliefs are almost same in north, south, east, and west. Only thing differs is the magnitude. In north, the eclipse is given a very high weightage for occurrence of the cleft lip and palate. And here, a lot of parents are stigmatized because of the child born with cleft. We have many parents here whose husband has left, whose parents have left, Saas Bahu have left, or their parents have left, and they are bringing up children alone with the help of Smile Train, with the help of other organizations. This doesn't happen in South. I did not come across so many children. There, it happens there also, but not so many as many I have seen here. While in Chandigarh, the support system is so high that if there is any child born with any defect, whole society comes to help the family. I can't vouch about the Maharashtra. I know a little bit, but I can't say you know better than this. But in central part of India, it's an area where a lot of bhoot, pret, toni, and all those things are talked about. These things happen more often in central part of India and eastern part of India. That this what you call the demons and the effect of bad eyes and all these things are prevalent in these areas much more. But once the child is operated, I have universally seen that all the parents, all the grandparents, they look forward to take care of these children. I have seen many of the parents and grandparents who walk to our hospital back after the child is operated and repaired because they look so normal. Nobody can make out that child has got any issue with the cleft lip and palate when they are. So there are variations in some part of the country and the magnitude is different. But overall, I think now the awareness is improving. And I think with the help of people like you, Sujit, and Dr. Rashmi, we should be able to inculcate the feeling of these parents through you, your organizations, you should be able to inculcate that these children are not because of any bhoot pret or anything, because of the eclipse or because of cutting the using the knife during pregnancy. It has happened. It has happened because God has given like this. Genetic, we can blame only in 18 to 20% of patients. We can trace the generations, but not in rest of the 80%. And very few patients, they come out with acceptance that they had taken some drugs or they had some viral fever or they had taken some medicines during pregnancy. Very few. Rest of them are only, I can say, it is all environmental factor. What I mean to say in nutshell is all these myths we need to mitigate, and this is our responsibility, collective. And I'm sure we have achieved to some extent, but not fully. Long way to go, I think.
Great word, sir. Thank you.
Thank you, sir. I would like to know if we have a registry of these patients.
No, this is a very big question, Dr. Rashmi. And I'm sure we talk about it every now and then. We talk in our meetings also. But the problem of registry is the government is not very ready to do this because it's a congenital anomaly of a small group of people. Second, I was part of the ministry in this area. I didn't tell others, but I can tell you that one of the reasons why they are not taking registry, ministry is not involved, is because a lot of NGOs are managing this. Now, very few patients are being managed by hospitals under the ministry or under the government. So their interest is less. ICMR started the registry work, but that also could not take in shape because the person who was trying to make the registry, he retired and now he has left the country. So there are many issues with the registry, and I'm sure one day help of Renu and Mamta, we should be able to do something on this. Yeah, it's a very pertinent question, and I feel that unless registry is there, we cannot really know what is the exact dimension of the problem. What I am talking about, the number of 40,000 or 35,000 or globally 2 lakh patients, this is only extrapolation. This is no registry. There is no data exactly to say that this is the number. Earlier, we used to talk about 35,000 patients. I said 40,000 patients because that extrapolation was done when the population was only 110 crores. Now our population is 140 crores, so we should calculate and make it 40,000 per year. That's how it is there. You are absolutely right, Dr. Rashmi.
Thank you, sir.
There is one more question.
Yes, doctor.
How early can cleft lip and palate be detected during pregnancy? And what prenatal care options are available for parents?
I think this question can be answered better by you.
Yeah, thank you, sir. Actually, cleft lip or cleft lip associated with palate can be diagnosed or suspected even at 12, 13, 14 weeks with advanced machines, good quality machines. Cleft lip is obvious in your nose chin view or coronal view. Just you can see the defect. But diagnosis of cleft palate is very, very tricky and very difficult. See, in first trimester, it is somewhat, if you are very careful in your examination, it is easy because in first trimester, the palate is flat. So even though the tongue is there and all those things is there, ossification is just complete, you can assess, you can visualize all the things clearly. But in second trimester, the palate is dome-shaped structure. Again, it is in the oral cavity, and side by there is another organ, tongue is there. So visualization is very, very difficult when we are talking about isolated cleft palate. So when two important things, whether the patient is low risk or high risk. Low risk means there is no history of cleft palate, lip or palate in your family or some relatives. So just the uvulus, the equal to sign, which has been mentioned by Dr. Rashmi just now, the visualization of this rules out your isolated cleft palate. But when in high risk cases, when you want to rule out isolated cleft palate, then you have to have some very extended view of your fetal neck, which I have covered in my last talk, so that in real time, when the baby deglutes, takes water into the mouth, you can see the entire palate very nicely with clear sign. Regarding second part of the question, what prenatal care you can give, there is nothing directly which we can do about this cleft lip and cleft palate, but yes, you can counseling, which is the most important part in this, as Dr. Karun Agarwal sir has told. You can counsel the parents about this. You can have a meeting with pediatrician or maxillofacial surgeons or pediatric surgeons before delivery. We can look for whether other complications of cleft lip and cleft palate, for example, polyodontia. You can tackle those complications, but directly you cannot do anything about cleft lip and cleft palate prior to delivery. Anything you want, Dr. Rashmi? Yes, sir.
I think the question is directed towards prenatal or intrauterine surgery. Intrauterine repair of the cleft lip and palate. Probably that's the direction of the question, I think. Now, at the moment, there is no place for intrauterine repair of the cleft lip and palate. A lot of attempts had been made to repair the cleft lip, and I was part of one of the study in US where the created cleft lip in pigs we used to repair intrauterine. But it failed in clinical practice because of the risk of the termination of pregnancy or abortions, a very high incidence. And there were a lot of management problem of the patients after doing surgery. The clinical work was done in Los Angeles in one of the centers, and after 6 cases, they stopped doing it. But definitely the repair, if it is done intrauterine live, which we saw in pigs, the scar is almost negligible. It is not visible at all. So these are the cases which probably in future, when all these genetic and stem cell things are coming, and I'm sure in due course of time, intrauterine surgery may be possible. All technology, we can't say what is happening there. And with the help of newer technology, we should be able to create lip repair and palate repair without scar. It should be possible. That is the future of this.
Yeah, right now the intrauterine surgery for spinal bifida has been working on very nicely and successfully. So hope in future we may carry the same thing on cleft lip and cleft palate.
I'm worried that you will take care of all these patients without our help. will become jobless.
Sir.
Yes, Dr. Singh.
Let's see. Thank you for this answer, sir. Any other questions, Shrutika? I don't see any.
No, sir. No, sir. That's all.
So let's come to the last part of this webinar, Thanksgiving. Thanks a lot for Smile Train and Amox for coming with collaboration to make awareness, to increase the awareness about cleft lip and cleft palate among all the societies of Maharashtra. Thank you, Renu Mehta ma'am, Dr. Pardeshi sir, and Dr. Sujata Dalvi ma'am for this. Thanks a lot for our speakers today, Dr. Rashmi and Dr. Karun Agarwal sir, for very excellent and nice talk. Thank you, Science Integra, for providing this platform. Most important thing for today, most important part of webinar is the delegates. Thanks a lot, all delegates, for logging in today. I appeal all those who are watching this webinar to refer any patient which come across to you, patient of cleft lip or cleft palate, refer to Smile Train. You have seen all those pictures, photographs, and talk of Agarwal sir. So this is very nice thing. You can say that the effect of the treatment part and all those parts are very nicely covered by Smile Train. So again, appeal all those to refer their patients to Smile Train. Thanks a lot.
Thank you so much.
Thank you
A
everyone.
special thanks to Science Integra, Renu Mehta Madam and Shruti and Bajaj Pinsal.